Good afternoon, everybody. Thank you so much for joining us for today's webinar, Expanding Access to Care for Justice-Involved Youth. My name is Autumn Boylan, and I am a Deputy Director at the Department of Healthcare Services. I am really excited that we are partnering with the Office of Youth and Community Restoration on today's webinar, as well as Kindful Restoration. You're going to hear from Ernesto Rodriguez today, and hear about all of the wonderful work that they're doing as part of the Justice Serving Network with OYCR. And we're going to share a little bit of information about the County Justice Involved Reentry Initiative, as well as the work for the Children and Youth Behavioral Health Initiative related to our school-based services program. Thank you all so much for joining us today. I have the pleasure at DHCS of overseeing two seemingly distinct areas of work, partnering with schools to improve reimbursement and supports for students in school-linked settings, as well as working with correctional facilities to implement Medi-Cal reimbursable pre-release services and care management transitions to help people reintegrate back into the community after release. And although it does seem on face that schools and correctional facilities are very different, the work is actually so well complemented and aligned, and focusing on justice-involved youth is a big part of kind of what we're doing under both of these initiatives, and making sure that young people are getting access to the necessary services and supports that they need in order to prevent contact with the justice system, or to successfully reintegrate if there has been contact with the justice involved system. So we are really excited to share some information with you all today, and we'll go ahead and get started and jump into today's presentation. So as I said, we're going to hear from some of our partners today. I'll introduce my colleagues at OYCR in just a moment, and then we'll hear from Ernesto Rodriguez. We'll give an overview of our Justice Involved Initiative and our School-Based Services Initiative. Hopefully we'll have some time for questions. We encourage you to drop your questions in the Q&A feature as we are going through today's presentation. We'll answer those as we go throughout. And we'll also monitor the chat, so engage with us as we're going, and then we'll open it up for questions towards the end of today's webinar. I think with that, I'm going to turn it over to Lisa Tadlock from the Office of Youth and Community Restoration to share with you a little bit about what they are doing to support justice-involved youth through the Justice Serving Network and otherwise. Lisa?
Great. Thank you, Autumn. First of all, I really want to thank DHCS for working with us at OYCR. This has been a great opportunity for us to collaborate. So my name is Lisa Tadlock, and I'm a health program specialist in the Office of Youth and Community Restoration. We are a new office under California Health and Human Services, established under SB 823. I put our website link in the chat if you wanted to learn more about us, if you are not that familiar with OYCR. The goal today is we want to showcase and highlight some of the activities that we think that our community-based organizations and other partners can utilize to service youth in the justice system. So under OYCR, we were pleased to be able to have a community-based organization implementation project. And so what we did was we funded 28 CBOs around the state. And today we have invited our one of our partners, Ernesto Rodriguez from Kindful Restoration, to share one of some of the work he's doing, particularly around community health workers, and it ties in well with what you'll be hearing later on in this webinar in terms of, but he's doing some fantastic work. All of our community-based organizations are doing some great work, but I really, Ernesto has just really been out there and just has really done a great job in promoting this work and promoting, the community health worker process. So I don't want to take too long. I want to give as much time as I can to our speakers. So I'll turn it over to Ernesto, and you can do a brief introduction and then share what you're working on.
Thank you, Lisa, and everyone here today. Before I get started, I just want to say I'm Ernesto Rodriguez with Kindful Restoration, and I'm humbly grateful to be here today to speak a little bit. And I also want to give thanks to Lisa, OYCR, DHCS, the platforms that they made possible for community-based organizations to do the good work, and working with our youth. It's just I'm blown away to be part of this transformation, um, particularly in our county and Riverside and more the Inland Empire and across California. But this platform allowed community-based organizations to tap into the healthcare business. Um, that's what they call it in the PAVE portal, other healthcare care business. And that Senate bill that was passed allowed people that do the groundwork in the communities to get creative, because that's what community-based organizations do. We get creative to do the work. And the topic today is community health worker, CHW. And one of the problems that we identified as we got deeply involved um, in this work is that one of the things that was a big roadblock was housing. Whether you're in the institution and getting ready to, be released from the detention centers, or even in the community, not being not having housing and not being stabilized was a big deterrent and something that oftentimes caused, young people to get back in the mix and survive. And because of that, they say that when a youth is released, within 45 days they're back in the facility, and that's a pretty quick turnaround. So we've been working closely with probation to change things around, and I know one of the things that OYCR is advocating a lot for is the LRPs, which is one way to address this problem. But at Kindful Restoration, we put our thinking caps together, and we were like, okay, we're doing CHW, we're doing ECM, and we're doing community supports, housing. How can all of these communicate together? And I know when DHCS and the bill that passed, Cal aim really is to save our state dollars. How can community-based organizations, um, you know, do the work at a reduced cost and get probably even better results in many instances? So if we could go to the next slide, please. Um, so with that being said, one of the things that community-based organizations do well is that we build reports, that community engagement. And part of the promotores and promotoras of what they do, which is CHW work, building that rapport and that bridging that gap of communication is something that community-based organizations are well versed in. And so when you're talking about determinants of health, when you're talking about risk of homelessness, when you're talking about homelessness and this particular problem with housing, the engagement was there. And so with that engagement, if we go to the next slide, we said, how can we leverage the CHW dollar if many of you know that for CHW, you get about 26 something per unit. And in many instances, you're allowed to build up to 4 units per day. And one of the things that I realized was that housing one youth at an institution, it cost about $160,000 or around there to house one youth in a facility. And so we put our thing caps together and we said, okay, well, let's try to borrow a little bit from the transitional housing model, and how can we replicate that in a way where we can reduce homelessness or risk of homelessness with the CHW dollar. So what we did, if we can go to the next slide, is that we opened homes that had the capacity to house 6 youth. And we also trained and certified community health workers to be for the community health worker to be the house manager and to be able to provide the CHW determinants of health and also stabilizing the persons or the members that we were engaged with in these homes in order to stabilize them, um, educate them about health, give helping them and supporting through financial empowerment. And what happened is that we realized that 4 units per day for one person equaled about $110 per day, which was a lot less if you did the math per year of what it would cost to stabilize 6 youths in one of these homes, as opposed to they're going back into the institution within 45 days. And so what we did is in that time that we worked towards reducing homelessness or risk of homelessness and stabilizing them, we also taught them how to become responsible, how to work towards employment. Many of the youth were transitional youth, so ages 18 to 25. And once they were employed, we said, okay, if we go to the next slide, we said, okay, so now that we are able to sustain these homes at a very low cost, if we go to the next slide, we're able to graduate them to phase 2. And phase 2 really meant now we're getting authorizations for housing navigation because we get into the realistic phase of finding permanent housing. And so once we were able to get to that step with that particular person or young person, then we would go to step 3, which is housing deposits and assist with the moving costs. And once they got to that point, then we provided housing tenancy and support services in order to support them and educate them to have relationships with the house managers, the landlords, how to pay rent on time, how to stick to the program, how to continue to go to work, how to sustain themselves and maintain themselves so that this dollar, this CalAIM dollar, this CHW dollar stretched all the way through the process to the point of having success with this particular model. And then once we exited the CHW homelessness or risk of homelessness process, then we said, okay, well, how can we also educate them about connecting with their PCPs, making sure that they're investing in their self-care, making sure that they're taking care of themselves. We then were able to provide enhanced care management to provide that support, that education, connect them with the resources, support them, sometimes even transportation to the doctor's appointments if it was necessary. And if we go to the next slide, through this process, we quickly identified that as we were doing the work and documenting every step of the way, leveraging the dollars that we were putting into the housing model all the way through the process, as a community-based organization and new to the CalAIM space, we were audit ready by design through our model that we put together. Checking eligibility, authorization, daily verification, submissions, and even retentions now with the redetermination process. If we go to the next slide. And so our Kindful Restoration model really leveraged what CalAIM was intended to do for community-based organizations. We were able to use our CHW work in order to stabilize people that really were having care gaps, and even um, homeless or at risk of homelessness. We were able to connect with housing partners. A lot of our housing partners we subcontract in order to provide. What we do is we pay $80 per day per bed for each member or each person that we're housing, and then we're still making about 26 or $30 per day for providing the support with the promotor or the promotora, and then also making sure that the healthcare model encompassed educating many of our members and the people that work with healthcare, because you'll be surprised how many youth don't even think about their self-care, or how important it is to, go to regular checkups, their yearly checkup, to invest in, and making sure that they're okay. If we go to the next slide. And so I think that as this work continues to unfold in the state of California, I believe that because of the success that we've found in the housing model, particularly, the dollars that we're saving the state, essentially, um, we could even say that, um, we can house and stabilize individuals for about half the cost of incarceration or institutionalization, and also significantly reduce recidivism, um, with less systematic strain. And that stability, we believe, especially with our CHW housing model, um, I believe that it's a pathway um, to setting up our young people for success and stability long term, and also promoting and supporting them with their health access, health awareness, and then on the CBO side, or organizations that are doing the CHW work, um, kind of building from the beginning the integrity of from the point that we make contact with the person for initial homelessness or at risk of homelessness stabilization, just doing the eligibility checks, the ROIs, the daily notes, just being consistent and aware that, daily audits do come. And if you're diligent with the process from the beginning to the end, then when those audits do come to just take a look at how you're running your program, everything will be in place and ready to answer any questions that do come up. If we go to is that the last slide? Yeah. So I think that OYCR has done a beautiful job and investing at community-based organizations that really had no idea what CHW or ECM or community supports meant. They just knew with a lot of research that community-based organizations really had that credible messenger, that lived experience component that was very impactful and made the difference in our communities. Kindful Restoration started with, I think we had 4 staff. We had about maybe 5 young people we were working with. Today, we're over 24 staff. We're in 5 counties, and we're working with over 34,000 folks, in those counties. We're in the juvenile halls. We provide a pre-release program to set up the young people to have the tools and the support as they're being released and paired up with a mentor. And then on the community side, we we do leverage our community health worker services and the many other things that we do, um, consistent in support with the DHCS and CalAIM goals and missions. So we appreciate OYCR for having, walked with us and supported us, to get us to this point. Um, I'm not going to get too much into the genesis of how we got into this work, but just know that many of our staff, we've been there and done that, and sometimes we just needed someone to get creative to also help us, and that probably would have made the difference in our life. So we're just appreciative that we have had this opportunity to get creative and leverage the CHW work and dollars to be able to make an impact in our community. And I believe that was the last slide, right? Yeah. And so that's my presentation for today. I'll be honest, I was a little bit nervous. This is the DHCS, Department of Healthcare Services. They're the ones that approve, outpatient and all that stuff which were approved. We're an outpatient, intensive outpatient healthcare provider, and they sign everything. So this is a pretty big deal. And in partnership with OYCR, we're forever just grateful at the opportunity to be able to serve our community and share the innovative ways that we've been able to leverage, particularly the CHW work, because the dollars for CHW they're not the best. However, we were able to get creative to kick butt and reduce homelessness or risk of homelessness, and also be able to stretch that dollar to run these homes. So thank you.
Thank you so much, Ernesto. It's great to hear kind of the model that Kindful Restoration is using to support justice-involved youth. I think it might be helpful just for our audience to kind of back up and a little bit talk about some of the programs that we are administering at the Department of Healthcare Services, where community health workers play a critical role in the delivery system. As you said, Ernesto, community health workers are really part of the community, right? Like they're individuals with lived experience. That's one of the criteria for providers to be considered a community health worker, is that they have lived experience working with the populations that they're serving within the Medi-Cal context. And community health worker services are available in our fee-for-service Medi-Cal delivery system, but also in our managed care delivery system, and play an important role in a team-based setting around enhanced care management, particularly when we're talking about helping people transition from a youth correctional facility back into the community. You really do want that credible messenger, that somebody who's kind of been there, who can help really support and show our young people that there is hope for them to be able to recover and integrate and move forward in their life, and move beyond kind of the experience of justice involvement and adverse childhood experiences. So in the context of this work, it's not just community health workers. We also have peer support specialists in the mental health space who play a similar role. Peer support specialists is a provider type within our county behavioral health delivery system, also a part of Medi-Cal, but they play similar roles. So lived experience of mental illness and substance use disorders, is really what the role of the peer support specialist within our delivery system. And then for community health workers, that lived experience working with populations, and specifically lived experience around justice involvement or homelessness, or any of the other kind of factors that really kind of drive the outcomes that we're seeing with justice involved youth. The scope of a community health worker. Oh, go ahead.
Yeah, no, I mean, now that you mentioned that, I never imagined that my part of my resume of being formerly incarcerated would make such an impact in all of this work that I'm in. Being a justice involved provider for the Inland Empire, and my staffing model of formerly incarcerated persons that have other different lived experience, our staffing model really encompasses and focuses on making sure that we have formerly incarcerated folks. We go out of our way to get all those fancy trainings as well, peer support specialist, and and our community health worker certification program. But the lived experience with this particular population of focus, having been through that process of having been formerly incarcerated to the point of change and going through that process of change and figuring out what we were going to do with our life, differently. The last time we got, maybe some of us got our second chance, some of us had 10 chances. I often tell people that, man, I had like about 100 chances before I got it right. And just having navigated that process and having that empathy and that understanding that, what, things do happen in our life. We make poor choices. We grow up in environments that are disadvantaged. We go through traumas that are not easy to work through. Therapies, counseling, self-help programs. I mean, you name it. Our staff went through it to get to this point, to be able to serve our young people that are going through that now, going through domestic violence, growing up in domestic violence homes, and just not knowing how to communicate the pain, the isolation, just the desperation of being in a situation that you have no control over, and then the behavior is kind of like a byproduct of what's really going on at the root of where the pain that a young person is experiencing. So that particular experience that we have at Kindful Restoration, I believe, is what has made the difference in our region, in our counties, with probation, with parole. They're always, Kindful Restoration, we need you to do this, we need you to do that, and we're like, we're glad because we're living the dream. Many of us that went through the transformation process, we often said, hey, if we ever got the shot of, this is how we would make amends. We'll become counselors, we'll become facilitators, that's how we're going to contribute and give back. And I think that our whys, because of that, it's made a big impact in our community. We're always willing to go above and beyond to, I mean, last time, two of my counselors, they're like, hey, we had this young person that just didn't want to show up, and we just went to his house and we talked to his uncle and we talked to his dad, and he was like, nobody's ever showed up at my house like that before. And we're like, man, homie, that's because we care. And that language, that rapport, and it just made, now they're going through our CHW training process and they're buying in. They're there every day, staying out the streets. And it just, working with a justice involved takes a special set of skills. And I don't think you have to be formally incarcerated, but you got to know the struggle, because the struggle is real. And I think that the fact that the Department of Healthcare Services, the fact that you guys made a space, you guys listened and made a space to allow people with that lived experience to do the work, because nobody cares how much you know until they know how much you care. And I think that that space that was created allowed us to really make a difference in our communities. And honestly, I get emotional talking about it because I served 24 years in the institution. And now they call me, I'm a founder and an executive and all this fancy stuff. I'm just doing what I was born to do, because I wasn't born to be incarcerated and to be sad and all that stuff. I was born to contribute to my community. So OYCR and Department of Healthcare Services, thank you on behalf of all community-based organizations that are doing this work in the state of California. Thank you for making a little space for us to work in our communities. That's what this is all about. And we thank you from the bottom of our hearts.
Well, Ernesto, I think that we couldn't say more how grateful we are for the work that you're doing and for being here today to share the story of Kindful Restoration and your own personal story as well. I think it's so meaningful when we hear from our community partners and really bringing to life the work that you're doing in communities, which is not what I do, right? Like, I work in Sacramento, right across from the Capitol, and I try to think about how to make the Medi-Cal program better and make sure that kids are getting connected to care, but you're the one that's actually out there making it happen and making sure that kids are staying on the right path and that you're training new people to do what you do, I think is amazing. And we're really grateful for the partnership, and also just showing some of our other partner organizations that are on the call today what this kind of model could really work like. Because one of the things that I really heard from you when you were sharing your presentation is about not just all of the work that you're doing, but the partnerships that you have with the managed care plan as an ECM provider, with county probation, with, all of the local providers, the housing providers in the community. That's really what being a community health worker or an enhanced care management provider is all about. ECM is meant to be a wraparound, whole person care support to help people navigate the complicated healthcare delivery systems in California, particularly, navigating that within the managed care context. So getting folks connected to their primary care provider, getting folks connected to behavioral health services, and making sure that they are working towards, recovery with a provider that's covered under the Medi-Cal program, and making those connections, I think is key. And having folks who have that lived experience can really make the difference in terms of somebody taking that first step towards help seeking or taking that step back towards the wrong road, right? And so I think you're really the one showing us the way. And thank you for being here and for helping us to evolve kind of both our ECM program and our community health workers program to make sure that there is a space for the work that you're doing, because it's so critically important to making sure that our young people are thriving in California.
Yeah, and I thank you for having me here too, and just the impacts that are happening because of this opportunity. It's just, it makes all the difference. The young people are the ones that are benefiting from this, this creativity and this shared partnership. Like one youth that we have, he went from juvenile life to now he gets dropped off every day, and he's on his way to, going on formal probation and then ultimately off probation. So it's impacting them from the inside out for sure.
Yeah. Well, thank you so much. Maybe we'll move forward and now I just said maybe we'll just keep this conversation going, but I do want to tell folks a little bit about some of the ways within the Medi-Cal program and otherwise that community health workers can support the work and the kind of programs that are launching across the state, and the role of not just community health workers and peer sports specialists, but certified wellness coaches in the context of school-based services. So for our audience, understanding some of the programs that are really trying to incorporate enhanced care management and community health workers to support our justice-involved youth. So I'll just do a quick overview of our CalAIM Justice-Involved Reentry Initiative, as well as our school-based reimbursement program under the Children and Youth Behavioral Health Initiative. So again, just high level, I'm sure most folks have heard something about the CalAIM Justice-Involved Initiative, but in 2023, the Department of Healthcare Services was the first state in the nation to get approval from the federal government to provide Medicaid covered services during the 90 days prior to an individual's release from a carceral setting back into the community. And the whole purpose of the program is to help people navigate that transition, get folks connected to community-based supports through enhanced care management, with community health workers playing a pivotal role in the delivery of ECM services, and engaging people not just in pre-release services, but in post-release supports under our Medi-Cal delivery system, and particularly our Medi-Cal managed care delivery system, since most of our Medi-Cal members in California are enrolled in a managed care plan in their county. So the criteria to participate in the program is first that the individual has to be Medi-Cal eligible. So if they're eligible but not yet enrolled, then part of the program is to make sure that folks get enrolled in the Medi-Cal program through our Medi-Cal pre-release application component of the program. But if somebody is eligible for Medi-Cal and they're not yet enrolled, that still counts. We'll work towards helping them enroll. But you see kind of the eligibility criteria here. This program is a Medicaid program. So about 80% or so is our estimate of individuals who are incarcerated in county youth correctional facilities, in county jails, and in state prisons across the state. And this is a program for our Medi-Cal members who are incarcerated in those facilities. So in addition, though, for youth, there actually are no additional healthcare services criteria. And the way that we define youth in the context of this program is that it includes young people ages 0 to 20 eligible under our Medicaid and CHIP program, but also former foster youth up to the age of 26, regardless of the type of institution that they were incarcerated in. So it doesn't necessarily have to mean that they're incarcerated in a youth correctional facility. It could be a young person incarcerated in an adult jail or in a state prison. They're also still eligible without having to meet any additional healthcare criteria. For adults, however, who do not meet one of those definitions of youth, there are some specific healthcare criteria that adults must meet, including having a mental illness or substance use disorder, having a chronic condition or significant clinical condition, an intellectual or developmental disability, traumatic brain injury, somebody with HIV or AIDS, or somebody who is pregnant or postpartum. Next. And the program is really centered, as I said, on that coordination of care and care management to help people transition from the pre-release environment of being in custody to the post-release environment of being in the community. So the foundation of the program is really reentry care management services. That includes a warm handoff with a post-release enhanced care management provider. Even better if that's with a community health worker who has lived experience of incarceration or justice involvement, or a former foster youth, for example, who can help young people navigate that post-release space. But it does also provide for coverage for other services during the pre-release period to help diagnose, stabilize, and treat individuals with medical necessity and the needs that we identified in the previous page. So physical and behavioral health clinical consultation. So somebody who has a significant or clinical chronic condition, for example, can get access to diagnostic services. They can get stabilization services and treatment, and behavioral health clinical consultation. So psychotherapy, whether that's for an individual or a group, for example, care coordination, lots of screening components, assessment to make sure that we're able to identify the needs of individuals while they're still in custody, establish a reentry care plan, and make sure that they're getting those services in the community as well. It includes laboratory and radiology services, medications, including medication-assisted treatment or medications for addiction treatment, MAT services, as well as services provided by community health workers with lived experience, prescription medications in hand upon release, and access to durable medical equipment upon release when needed. Next. One of the core components, like I said, we're going to focus on care management today, but we do want to make sure that all individuals who have a mental health condition or substance use disorder are connected to community-based behavioral health supports as well, whether that's through our county behavioral health agencies for specialty mental health services and drug Medi-Cal or drug Medi-Cal organized delivery system services, basically our specialty behavioral health level of care, or whether that is through our Medi-Cal managed care plans for individuals with more mild to moderate conditions in our non-specialty mental health services level of care, or for individuals who are on MAT and can be treated by their primary care provider in a managed care setting. We want to make sure that those links are happening, whether it's to the managed care plan or to the county. So this is one of the foundational components of the Justice Involved Initiative, and requires the correctional facility to make those linkages to the counties and or the managed care plans, to do professional to professional clinical handoffs, and to make sure that folks are getting access to peer support services from individuals who have lived experience with mental illness or recovery from substance use disorder, while they are receiving support through our county behavioral health delivery systems. Next. The other big component of the care management structure is that post-release care management support. So we've been talking all throughout this webinar about enhanced care management, and really wanted to kind of provide a little bit of an overview of what ECM is all about. So it's a Medi-Cal benefit in our Medi-Cal managed care delivery system. There is a specific requirement for managed care plans to provide enhanced care management services to individuals who are justice involved. It's a specific population of focus and a core aspect of the Reentry initiative, where the pre-release care manager, if the pre-release care manager is either an employee or a contracted provider of the correctional facility, then they would need to do a warm handoff to a post-release ECM provider that is part of the managed care plan's network of care, so that the managed care plan is covering the services that the member receives, that the ECM provider can get them connected to other providers within their managed care plan network, like primary care providers or specialty care providers or behavioral health providers. And it is the role of the enhanced care management provider to really provide that whole person support. So they should be helping our members navigate to all health, behavioral health, and social supports, including housing navigation, tenancy supports, and transitional rent services when the member is qualified and receives authorization for those services. So you see here, like the core service set is that health promotion, member and family supports, that care management across the delivery system. That's really that wraparound whole person care support. Next. So in the context of the Reentry initiative, I spoke to the warm handoff requirement. We do want to make sure that while people are still in custody, they're meeting with their care manager that's going to be working with them in the community. It helps to build the relationship, to start to build trust. That is even more successful when a community health worker is part of that ECM team of providers that's helping to get folks connected to that post-release care, and to develop a reentry care plan with the member, so that they know what supports will be available to them in the community. They know who their point of contact is in terms of the ECM provider, and they are able to have that lifeline when they get released from the carceral setting. Next. This is just a little bit more detail about the role of the pre-release care management services. So the pre-release care manager could be the community-based provider, by the way. That's part of the InReach model, where the correctional facilities can allow community-based organizations to come into the correctional facility to provide those pre-release care management services, which is an ideal model, right? Then you have the person that's doing the pre-release care management is the same individual or organization that's doing the post-release care management. So that's one of the allowable models under the waiver program. And in that role, the community-based organization, if they're providing InReach supports, would help to coordinate the health risk assessment, do those pre-release care linkages within the correctional facility, make sure all of the appointments are happening, make sure all of the medications are ordered, that DME is ordered, that the member has given consent for data sharing and exchange of of records that will help the providers in the community to be able to provide the necessary services and supports. Already talked a little bit about the warm handoff and the reentry care plan, but making sure that the individual is getting connected to behavioral health, to physical health, and those social supports is critical. Next. And so just a little bit of a deeper dive into the community health worker and the pre and post release. So community health worker services can be provided by community-based organizations during the pre-release period as an in-reach provider, as a part of an ECM care team, to make sure that we have those people with lived experience, those credible messengers, those trusted community-based partners, like we heard from Ernesto that they're providing to individuals as they're navigating the reentry process from the custody setting back into the community. I think particularly important around, youth who may, not understand how to navigate the healthcare delivery system, who need that extra kind of support to get connected. And so in this space, I think even more critically important to help the family understand how to support the young person in this transition. And then in the post-release environment, all of the things that I just talked about in terms of ECM services, the community health workers have a role in providing those post-release ECM supports, including everything that you see here on the slide and that I've talked about previously. Next. And then again, same thing with the peer support services. So these are also approved peer pre-release services, would be offered by our county behavioral health agencies when somebody has a need for county level specialty behavioral health. Then and particularly with justice involved youth, that is the most likely scenario, given the adverse childhood experiences and the trauma faced by youth in a carceral setting, or just what even led them to be incarcerated in the first place, that through the county behavioral health agencies, they can also provide peer support services both during the pre-release period and upon release as well. Next. I'm going to transition a little bit to our Children and Youth Behavioral Health Initiative fee schedule program. This is our school-based services reimbursement program, where I mentioned earlier that these are really kind of on face. They seem like they don't go together, but in my role overseeing both of these programs, I very much see some of the parallels in terms of our healthcare delivery system learning to partner better with other systems of care that provide services and supports to children in a variety of ways. So in our schools or in our youth correctional facilities, there's an important role and much more connection that we can make between our Medi-Cal managed care delivery system, our Medi-Cal fee-for-service delivery system, and kids who are being served in these other systems. And so the fee schedule program is another place where community health worker services can be delivered by community-based organizations through schools. And one of the great things about the fee schedule program is that this is not just about Medi-Cal. So this is a way for us to provide supports to kids with commercial insurance, or with a disability insurance plan, where we can get reimbursement through the structure under the CYBHI. Next. So what is the CYBHI fee schedule program? It's really a reimbursement program. So we don't tell schools, local educational agencies or school districts or colleges and universities who they have to serve or what types of services they have to provide. But what we know to be true is that all across the state, schools are typically a very consistent place where young people, particularly young people with a high level of needs, are getting access to services and supports in their community. Particularly in small counties, there may not be other providers and CBOs and organizations that are serving youth. So we want to make sure that our schools who are providing services and supports are able to get funded for that work in a sustainable and consistent way. And that's where the role of the managed care plans comes in. Under the statute for the Children and Youth Behavioral Health Initiative, managed care plans under the Medi-Cal program, as well as our commercial health plans and disability insurance plans, are required to reimburse school districts and colleges and universities for services that are provided to treat behavioral health conditions or emerging behavioral health conditions at a school or school-linked site. And so there are just under 1,000 school districts throughout the state, over 100 California community colleges, and several universities in the state. And so a large population of students under the age of 26, because the CYBHI is limited to children and youth ages 0 to 25, that are getting support from schools and community-based organizations that partner with schools to support students and families every day. And so this program is meant to help provide that reimbursement infrastructure. Next. As I said, this is for some students. We used to, in the beginning of this program, refer to it as the all-payer fee schedule program, but that's when we didn't know as much about health insurance as we do today. So now we actually refer to this as a multi-payer fee schedule program. Just like I said with the Medi-Cal program and for incarcerated individuals, about 80% of the student population in California is covered under a plan that is obligated under the statute to reimburse schools for these outpatient behavioral health services. There are some things that are not included, including for young people who have who are enrolled in a federally regulated plan, so like TRICARE or an ERISA plan, for example. If the family is enrolled in a high deductible health plan with a health savings account, they may not be eligible if their deductible is not yet met, and self-funded insurance plans where the provider provides the insurance coverage, or the employer, provides the insurance coverage as the health plan in the organization, then they are also not covered. But again, about 80% of the student population is covered under this program. Next. One of the great things about the fee schedule program is not only that it is a multi-payer initiative, but that it allows for the reimbursement of services provided at a school site. And the way that the school site is defined in the statute is that it's at school, meaning on campus, or at a school-linked site. So regardless of whether it's on or off campus, if you're a community-based organization that works with the school and you go into the school and provide services on site, that's great. You can participate in this program. But even if you provide services in the community, it's also allowable as long as you're partnering with schools to deliver those school-based, school-linked supports. So the statute says that it's at a location where the school or district provides or arranges for the provision of medically necessary services. And it specifically says that includes off-campus, on campus, or other similar locations. So telehealth is also included if you're working with the school to provide telehealth behavioral health services. That's allowable. Next. And so there is, multiple different kind of pathways for community-based providers to participate, and we have specific guidance posted on our CYBHI fee schedule program website that goes into the detail about the steps you would need to take if you were partnering with the school to deliver services. But the kind of key to all of this is that the school or district has to kind of designate you as a community-based organization as a school-linked provider. So there's a couple of ways that that can happen. They can contract with your organization, and then the school district would be the entity that would submit a claim for reimbursement, and they would pay the CBO as a part of their contract. Or they could add you to their provider list, similar to the way a managed care plan network, provider network would operate. In this sense, we're kind of saying that the schools have a provider network, and if they put a community-based organization on their provider roster, then that organization becomes eligible to participate in the program. We also have a few organizations that have been designated as statewide affiliated providers because they're serving multiple school districts across multiple counties in the state. And we wanted to make sure there was a pathway for those providers to be able to serve all of the students that they're serving across the state. So that's also an option if you're one of those types of organizations that's working with many, many school districts, then that could be an option for you to pursue. Next. Today we have 100, oh, well, as of April 20th, I should say, we have 174 school districts in the state that have started to submit claims for reimbursement. We've reimbursed as of April 20th, $8.2 million, although I will say as of this week, that number is $9.8 million, so increasing. And then and there's 36 health plans in the state that are represented in the claims data who are responsible for paying these claims. So that's just under 37,000 students as of April 20th have received services that have now been reimbursed as part of this fee schedule program. But we know that there are hundreds of thousands of students across the state who are getting behavioral health services and supports at school or through a school-linked provider. And so we're really seeing a lot of growth, but our focus now is on scaling the program to make sure that all kids and youth in California are getting access to behavioral health services and supports, and that school districts are getting reimbursed for the services, and our school-linked providers are getting reimbursed for those services. Next. Today we have kind of a mix. We have some licensed providers, about 43% of providers that are represented in our claims data. We have school counselors, school psychologists, and school social workers also providing services. Certified wellness coaches, which is a similar type of workforce classification to community health workers. We're not seeing a lot of community health workers in the data yet, although it is allowable for community health workers to get reimbursement under this program as well. And we recently got a state plan amendment approved by the Centers for Medicare and Medicaid Services to ensure that schools and local school districts particularly can be supervising providers for community health worker services. So if you are working with a school district as a community health worker, there is a pathway for reimbursement under this program as well. And there's the certified wellness coaches benefit, which allows for people with an associate's degree or a bachelor's degree or the work experience of working with the youth population to be certified by our colleagues at the Department of Healthcare Access and Information as a certified wellness coach. And then obtain reimbursement. So I would think of CHWs and certified wellness coaches as part of a career ladder where you have community health workers who are adults 18 or over with lived experience. Then you have certified wellness coaches who may have an associate's degree or a bachelor's degree. Then you have maybe an associate level or clinical trainee level provider, somebody who's working towards licensure but hasn't quite been licensed just yet. They can receive supervision. And then, of course, then the next step would be to become a licensed practitioner or a credentialed practitioner with a pupil personnel services credential. Next. And I know we're coming to the end, so I've only got another couple of slides, but the fee schedule program is an array of services. So it includes psychoeducation services, which could include skill training and development, for example, certified wellness coach services or community health worker services. About 30% of all of the claims billed so far are in that category. Screening and assessment, so performing those diagnostic evaluations, psychosocial status assessment, and brief emotional or behavioral assessments, as well as treatment. So psychotherapy, preventative medicine counseling services, group, so individual, group, or family, psychotherapy and counseling, and case management services. One important thing to note before we close out for today is that these programs, you can't bill under both of these programs at the same time, right? So the Justice Involved Reentry Initiative is for people who are receiving services while they are in custody. And the fee schedule program cannot be billed when people are still in a correctional facility, including youth correctional facilities. But once the youth gets out of the correctional facilities back in the community, you can either provide enhanced care management services through the managed care plan, and be a part of the ECM care team as a community health worker, or your organizations can work with schools to provide services and obtain reimbursement for the services that you're providing in that way as well. I think that we might have planned a little bit too much for today, but we can always plan another webinar into the future. And as we're approaching 4 o'clock, I did just want to say thank you all for being here as a part of this webinar. Hopefully it was helpful for you. I think maybe if we skip ahead to our contact, or maybe we'll just put it in the chat, the contact information where you can reach out to us if you want to ask questions about any of these programs. We can provide that information. There's also a ton of information on our website, and we'll be sure to connect you with information if you want a little bit more information about these programs. We'll go ahead and drop the email addresses into the chat. So thank you all for being here. Thank you so much, Ernesto, for your presentation, for sharing with us today. Honestly, like I thought about just not even presenting anything, but I know that's what, people were eager to hear about, some of the programs and how CBOs can get reimbursed, but it's so meaningful just hearing the story of Kindful Restoration and the work that you're doing in your community. Really appreciate that. And thank you to the Office of Youth and Community Restoration for asking us to partner on this webinar and to be a part of it. So thank you, Lisa and Dr. Massa and Director Lucero, for everything that you're doing in our communities. And we look forward to sharing more information with you all in the future. Thanks, everybody.
Thank you, Autumn. Bye.
Thank you, everyone.